few sessions. So Jay is the organizer for that. So I thought I will give a little bit of introduction into fluoroscopy and what is the history or evolution of fluoroscopy. And in the mid, if you have any doubts, you can always stop and ask me. And is my screen visible? Are you able to see my screen? Is everyone able to see my screen?
No.
No, not yet.
I shared it. No. No, you didn't share it. Again, Teams. Thanks.
Yeah, sub.
Yeah. Okay, do one thing instead of this 1 minute. Yeah, sure. Say it. Take this one. Select that. Now, okay. Is my screen
Yep.
visible?
Yes, it is.
Yeah, we just go ahead with it. I'll just talk to you about what is fluoroscopy. What do you mean or define by fluoroscopy? Fluoroscopy is the real-time imaging of the internal structures of the organ. It can be done either by introducing a suitable contrast media intravenously or orally. Okay, so orally is something called as a barium. Intravenously, we have a dye or a contrast that we inject into the blood vessel. So this defines fluoroscopy. So you see the real-time motion as it really happens within the body. Where and all it is used? It is used in most of the specialties like gastroenterology, vascular, orthopedics, gynecology, name it, it is almost used everywhere. So that is what fluoroscopy is, the definition of fluoroscopy is all about. I will just take you to a little bit of the evolution or the history of fluoroscopy. How did it really begin? Where did it really begin? So on the next slide, if you see that it all began in the year 1896, just before the year when X-rays and radioactive substances was discovered. So it all started with two different scientists performing different experiments, and they were working together at the same time, but the experiments were totally different. So as you see in the picture, one was Thomas, the other was Enrico, and these two people performed in a different way, but what they used is different material, and they came up with a device. Thomas came up with a device called as a vitascope, and Enrico came up with a device called as a cryptoscope. So if you can see a small picture in the middle of it, that's how it looks like. So how do you really view it? You put it over your head, and you have it in front of your face, and when the fluorescent screen glows, you're able to see a faint kind of an image onto that. So this is where the first discovery of fluoroscope. But what happened in this discovery was Thomas used something called as a calcium tungstate material, and Enrico used something called as a barium platinocyanide. So these are the different materials that were used. But on further experiment and further investigation, they found out that the calcium tungstate gave images that were very quite blurry, not well appreciated, but the images produced by the barium platinocyanide was of a good image quality for that time. So the studies carried on with this. With Thomas and his assistant Todd Clarence, they understood that there was some kind of a sickness that was eluding them. And for a long time before the effects of radiation was not found out, they didn't know this. But after that, they understood that radiation has some biological and chemical effects. So they kept this experiment as also an awareness program to say that in one way, radiation is harmful also. And Enrico and both these together, Thomas further with evolution and technological advancement, fluoroscopy was just developed. And an early picture of how fluoroscopy was initiated and started. So these are the pioneers who started off discovering fluoroscopy. Here I have a picture again about the early development of fluoroscopy. So the early development, one important thing in the early fluoroscopy was that people have to get adapted to dark rooms and wear red goggles. And this used to be for a prolonged time. Okay, so it was very discomfortable, but they couldn't do it in a bright light like this. That was the drawback. So this is an initial picture of the fluoroscopy where you see a metal, a long cone metal object. It used to be placed in front of the patient and where the X-ray source was behind the patient. And what happens is these plates had fluorescent material into it. So this phosphorus material would glow as the radiation falls on the plate. They would glow and give you a visual picture image. Maybe the image quality was not that appreciable at that point of time, but they could see some images coming up. So these were the initial way that fluoroscopy was started. So in this picture, if you see is here we see that a physician is trying to locate a bullet so that he can remove surgically. So that is this picture talking about. In this picture, if you see, this is totally an unprotected X-ray tube. Okay, there's no protection in the X-ray tube. The physician is holding this cryptoscope with his hand in between the tube and the screen, and he's trying to image his own hand. So these were the way the fluoroscopy started, the evolution of fluoroscopy started until late. And this image shows the advancement in the fluoroscopic discovery is that if you see the tube and the detector coupled to each other. So that's the first time that they were together. They were not elsewhere, they were together. So this was there, but the adaptation to the dark room continued. So still they had to go to the dark room, wear the goggles, see it on the fluorescent screen. This is what was happening. In the 1940s, this Dr. John Faltman discovered that image intensifier. So with modern technology, image intensifiers, CCD cameras, now we have flat panel detectors. We have advanced to do a very good fluoroscopic examination with very good appreciable image, reduce patient dose, improved collimation. So many dose awareness methodologies were followed so that you can reduce the dose and give an apt or an optimal image. So these are a little bit of how the fluoroscopy started. One more very important thing is this picture show you it was used to see the shoe fitting. Okay, in high-end stores, those times they used to have a fluoroscope machine where the foot used to be into it, and to overcome the problem of the foot fitment, so they don't have any fitting issues. So fluoroscope was done for that also. But later, when they found the effects of radiation, this was stopped. They even had a certificate where it will give you the ankle measurements, it will give you the weight distribution. So they had this scientific technology at that point of time for the shoe fitment. Okay, so it's again, as I told you, it stopped after it was found that it had harmful effects to humans. So that was stopped. So this is a little bit of the history and evolution and development of fluoroscope. Anybody who would like to ask any questions? Any doubts? Okay.
There was just a request. Can we record the session? Is it possible?
Probably not planned now. That I will anyway have another session later also. Probably we'll do that and give you, right?
Oh, okay, sure. No problem.
And here again we come to what is fluoroscopy? The key features, the key takeaways of the fluoroscopy. What is the key features? The first thing would be the live imaging. Live imaging is as it happens within your body, within the structures. You're able to visualize it, and you're able to come to a conclusion of what is really happening. Okay, so that is one key feature, one takeaway that we had. You use it with contrast agents. As I told you, contrast agent is something that you swallow or something that you inject. So in this picture, I just given you a diagram which we call as a barium swallow procedure, where a liquid is swallowed and your food pipe, your esophagus pipe is studied for any abnormality. Okay, in this case, we have it is an angiogram of the aorta and the iliac vessels, where we injected intravenously to find out. See, the entire vessel is nicely delineated, nicely highlighted, and you can find out, and along with your kidney arteries. So everything is well seen there. So this is in injection, and this is drinking. That's oral, right? And we also use it as a guidance tool. That is, whenever you are putting a needle into the body, or you're trying to do a biopsy, or you're trying to do a spinal injection or a spinal anesthesia. So I've given those needles here. See, there's a needle here going there. There's a catheter placement. So it also acts as a guidance tool. Where are you going? Are you going to the right place without damaging or going to the other parts and damaging other vessels? So it is also a guidance tool. So this is what the key features of fluoroscopy would be all about. Right? If you have any doubt, just stop me so that I can try to explain to you. Any one of you, okay? I'll just tell you a little bit of the vision, because we all know that human eye, the structure of the human eye is responsible for vision, what we see, what we appreciate on in we are working in a diagnostic imaging setup. So how do we see? A little bit of that. I've just given you a diagram, a cross-sectional image of the eye with the different anatomical regions and parts of it. Just to explain to you how it really works. As the light is incident on the eye, okay, it passes through a region called as the cornea, which is a very thin structure. So after it passes through the cornea, it passes through the lens of the eye. That is the next stage when it passes. Once it passes through to the lens, it goes and reaches the retina, which is the back part of the eye. Okay, and the retina consists of a number of tiny structures within a region called as the fovea. We call it as the rods and the cones. Okay, there are hundreds, millions of them, very tiny structures. The cones are usually at the back. The rods are usually at the front. How they are associated is the rods are usually associated with a dim light, lesser light. They're very sensitive to very less light. But the cones appreciate bright light. They are associated with daytime. They are very capable, or they're very sensitive to appreciate between different colors, different brightness, which is called as the contrast perception. Okay, so the main area of where we appreciate image, we appreciate light is the rods than the cones. A little bit of, and they are very sensitive to the different wavelengths of lights. So compared to cones and compared to rods, the cones are more beneficial. If you can see here, I've given here the cone and the rods. These are more important. Cones are more important in appreciating the light and sending that nerve impulse to the brain, saying that what is this? They call photostimulators. What these photostimulators are seeing in the brain. So this is how the vision works of appreciating an eye. Okay, human vision, human eye, when I see an image, can appreciate 20 shades of gray. But when I take a system, it can appreciate thousands and thousands shades of gray. That is why the constant development happens between image quality, what I see, spatial resolution, temporal resolution, contrast resolution. This is what we completely work about, and this is what the image quality is all about. Okay? How do you appreciate? If someone can tell me what is spatial resolution, contrast resolution, there's nothing wrong in interacting. I think it will make it more interactive, and probably you also can clarify your doubts. Anybody online? Okay, spatial resolution is the ability of the system to appreciate the tiniest of objects. What is the smallest of objects? You don't have to miss any nodules. You don't have to miss any calcifications. You don't have to miss subtle fractures. So if the system has the ability to appreciate this resolution, it has the best spatial resolution. That's why we talk about spatial resolution. Contrast resolution is again the ability of the system to differentiate between different shades of gray or two different objects placed close to each other. For example, if I have a spleen, I have a liver, I have a stomach, I have a esophagus, it should be able to differentiate these shades of gray. If it's not able to differentiate, you will not see an image. You'll see something which is very blank. That is why spatial resolution, temporal resolution, contrast resolution is very important in the terminology of imaging or the system. Right? Any doubts on this? What are the different types of fluoroscopy? In fluoroscopy, usually you have a pulse fluoroscopy or a continuous, and they are subdivided into conventional fluoroscopy or interventional fluoroscopy. This I will just come as I go through the different slides. I will try to tell you about that. Conventional fluoroscopy is nothing but related to very basic diagnostic fluoroscopies. Okay, I will come into that what it is a little later. And a subset of that is a pediatric fluoroscopy. Usually they are associated with low dose. Okay. On the other way, interventional radiology is slightly related to a higher dose. Okay, but in the intervention radiology, why people prefer interventional radiology is that the recovery time is faster, there is less pain, and it can replace surgeries. That is, it can replace invasive procedures. Invasive and non-invasive means that invasive is when you cut and open. Non-invasive is when you don't cut and open. You either enter through the body where you already have a hole like a mouth or like a nostril, or you just have a small jab into your skin or your artery and go into it. But that is interventional radiology. So it replaces what can be done surgically, can be replaced by intervention. Okay, but interventional again, the dose can be slightly higher dose. So that is the different types of fluoroscopy that we can use. Okay, and in pediatric fluoroscopy, whenever they follow pediatric fluoroscopy, usually they will have dedicated pediatric specialists to handle those kids, to give them the maximum comfort and see the outcome of the procedure is, out of the procedure is absolutely what you want to find out. Right?
So here low dose means the intensity of the.
See, the low dose means we have different kind of a dose settings. You have a low dose, you have a medium dose, you have a high dose, you have dose setting where you have a low dose, normal and high quality. You can choose that according to the clinical application. What are you doing? That is not relevant for every patient to be the same. These parameters can be changed for every single patient there. It is not a default or a set protocol that we always need to follow. It is when a patient walks in, that's why the history of the patient is very important for the technologist, for the physician who's performing, who's taking the patient inside. What are you looking for? What is the history? That is how you plan your study. I want a pulse fluoroscopy. I want a continuous fluoroscopy. Pulse fluoroscopy is between 0.5. Continuous fluoroscopy is between 0.5 to 30 frames per second. Pulse fluoroscopy will be between 0.5 to 8 frames per second for a PCF system. For a GCF system, you can increase to 15 frames per second. And we have something called the IQX or a spot imaging. I'll come to all that a little as I go through the slides. There we have up to 8 frames per second. So the capture will depend on what you are finding. Okay.
So also it depends on the part of the body. Which part you are.
What you think? It's not the part of the body. It's the it is like I told you, urology. So if I say urology, I'm looking at the kidney, ureter, and bladder. So that is my focus. If I say gastroenterology, I'm looking at the food pipe. I'm looking at the swallow, the esophagus. I'm looking at the stomach. I'm looking at the intestine. If I say gynecology, I'm looking at the reproductive parts.
It doesn't matter like whether you're going to like a scan for the bone part or the clay part, like it doesn't.
No, I didn't get you.
Like you are going to like for a body part.
No, we have an ASC system, an automatic exposure control, which will predetermine what are the optimal parameters required. Okay. I will go through it. It's too early to talk about it.
As you asked, there is not a single part. For example, you are doing a hand X-ray or something. Fluoro, we will be using a pathological live detection. For example, if you see all organs including one system. Here, if I want to see the esophagus, like my digestive system pathology I want to see, I will be including from mouth to complete this organ, where I have to see if there is any pathology obstructions are there, if there is any lesions are there, to see. That is mainly important for fluoro. Fluoro is not concentrated for one part. It's concentrated on systems like a blood system or heart system, or digestive system, as you told, urinary system. When you ask urinary system, what angle you have to cover? Kidney you have to put, ureters and bladder. To there you have including nephrology, then again from blood to
whatever contrast that you give, they are already opaque. They don't allow X-rays to pass through. That's why you're able to appreciate any abnormalities within that contrast region. Translucent is when it allows the radiation to pass. So these are the terminologies. So they are radio opaque. Okay, you can ask me questions as I go through it. I'll just tell you one by one so that I hope I cover it. If I don't cover it, then I'll come back to your question. So how do you reduce the radiation dose?
The fluoroscopy keeps on taking that exposure to get as a live steady kind of. So, in 1 minute, how many exposure that will take?
It depends on the setting. As I told you, 2 frames per second, 4 frames per second, 8 frames per second. This is per second, right?
Yeah.
This is per second. So whatever you set, you will get. If you say continuous fluoro, you within 1 second you get 30 images, right?
Yes.
So that is the frames per second. So when I say 0 to 30, that system is capable to give 30 images per second. 1/30th of a second it gives you image, millisecond, right? So it is capable to give you 30 images per second at that setting. If I go to 2 frames per second at one shot, that is one fluoro, it will give me 2 frames per second. Okay, so as you go, so 2 seconds will give you 4 frames, 3 seconds will give you 6 frames. It's like that. If you set it to 4, it will be double. So the setting is available, and what procedure you're doing, you can either defaultly take that setting or you can manipulate that setting manually. That's how you do it.
But if you compare that with RADX, where we RAD system, where we take one exposure and then edit it. So those, if you compare the dose in RAD system, where it will be higher.
I'm coming to that also. I'm coming to that. As you go, you'll try to cover that as well. So some ways that you can reduce the dose. How do you reduce the dose? By using a pulse fluoroscope. By using, not a high quality, but a low dose option which is available in our fluoro systems. When you use that low dose and use pulse fluoroscopy, your exposure is going to be optimal, but your image quality is going to be compromised. You're able to see images, just what you want to see, but you will not be able to appreciate finer details, the contours of the bone, any subtle details you might not be able to see. You have information, I want information, I have information. So that is where when you take pulse spot images, it avoids continuous fluoro. It helps you record that particular event immediately by having a capture, and later you can retrieve that also. You can store and you can retrieve it. So spot exposure happens within the fluoroscope. As the fluoroscopy happens, spot exposure happens. Spot exposure is equivalent to a RAD exposure. Okay, here the image quality is slightly, dose is less, image quality is slightly compromised. In this, you'll get a better image quality. Why? Means you want to store it, you want to view it, and you want to retrieve it back. Okay. Another thing is a last image hold that we give it in our system. That is, as you do a fluoroscopy, you'll have the last image as something that is on the screen saved. So what you can do is, in case you want to further carry on the examination by having a lesser field of view. But for example, I have done this fluoro. I don't want this area. I want only this. So what I do is I'll collimate. I will bring the shutters close. I will collimate and I will continue the fluoro. Otherwise, if I don't have the last image hold, what I do is again have to fluoro, again have to collimate and see. Here I have an image, I collimate. In that way, you reduce the patient doses. So these are the few ways where we can reduce patient dose.
Last image hold, it's a evidence of your procedure, like where you have stand. You are doing some procedure. That procedure can end up this thing and concentrated where you want to exactly located it, the further you want to continue, and that will give you the confidence your procedure is happening in proper way and avoiding the exposing other areas.
Right. So this next time I'll talk to you a little bit of the different categories of the fluoroscopy. Usually fluoroscopy devices come in 2 categories. One, we have the fixed system and the mobile system, mobile C-arms. The C-arms, again, in mobile, we call them as C-arm and a mini C-arm. These are more robust. They have a very, have you seen a C-arm?
Yeah.
Okay. They have they look very small. Okay. And they are more robust that they can be wheeled into any part of the hospital. So that is why C-arms are more preferred than a fixed system. We have another fixed system called the RF system, meaning that both radiographic and fluoroscopic images can be done with a single joint. You don't have to have a separate stapler detector, separate Bucky system, separate tube. Within, like we have a combi system, which is a 2-in-1 system. So both fluoroscopy and radiography examinations can be done with this system. So they call it as the RF system. Usually the C-arm, this is the C-arm. different versions. I said we have the mobile C-arm and we have the mini C-arms. Usually they have a workstation around here, they have the monitor here, you have the tube, you have the detector. So this is how it is being placed, and it can be moved around everywhere. It has a very small footprint, and the cost is also a factor. So they come with a cheaper price than what we have. So it all depends on the clinical application or the needs of the hospital, what they're catering to, whether they want to go in for a RF system or they want to go in for a fixed system or they want to go in for a CRM system. So these are the little different kind of category of fluoroscopic systems. So what we deal in DXR is we deal with proxy system and a combi system, a fixed system, which is also an RF system, radiography and fluoroscopic system.
We don't deal with this CM.
Pardon?
We don't.
That IGT. IGT takes care of it. You see all that high-end C-arms and high-end cath lab missions where you have the cardiac angios done off there because they're very high-end. You need to capture images within a fraction of seconds. Because if you lose it, you cannot. Contrast is something that can also have very adverse effects on your body. Okay, you can have a mild reaction, you can have intermittent. Have you heard of contrast reactions? Anybody? Anyone online? Okay, see, contrast also can, because anybody of us that we know, our friends, relatives can get into the hospital. Okay, so contrast, before giving a contrast, the first thing they will study is your renal function. Is there any renal impairment? How it is done by a simple blood test to see your urea levels, your creatinine levels, which should not be beyond 1.3. If it is abnormal, they will not give you a contrast. If you further give a contrast, it will impair your renal. You can go into a renal dysfunction, renal failure. So very important is that's why we have to finish these studies before the purview of time. I'm doing contrast so that I cannot keep repeating the contrast every time. There is a minimal dose according to the weight per kg, 2 ml you give. That's all. So if I have 60, I give 120. If I'm 450, I give 100. Something around that range. We just cannot repeat that procedures. It should be first time right.
Based on applications, there are the modalities. As you were concluded, there is a fixed system and there is a radiography with fluoroscopy and there is a intraoperative system. We call as a CR, which is only actually both which is upper one, which comes under this. See, the purpose of CM is completely different. It's intra-operative systems. Okay, while doing a procedure, corrective procedures. Okay, not diagnostic good procedures. See, whatever the two systems are there, they are diagnostic procedures. That's before you do a corrective operations or any procedure, you will be to find out what is the pathology, what is actually happened. That to find out those systems will help us.
But see, the difference with the C-arm is also the room configuration. You go into a room, the room will be configured in such a way that it can handle an emergency. There will be an emergency trolley, there will be an oxygen trolley. But with this fixed system, we don't have the room configuration. So probably many interventional procedures cannot be done, although they're capable of doing any interventional procedures. They will not be done because of regulatory purposes and because of the room configuration. If you have the right room configuration, you can use our systems for all interventional purposes also. Okay.
So flow system is fixed. Can we?
This is fixed systems. RF
fixed system.
Yeah.
So can we use for finding the blockage inside the head?
Yes.
Or we need to go.
No, these systems cannot be used for that because that's why I said they're cath lab systems. They're high-end systems. But they need to faster capture. In 1 second, I need 60 images, 60 frames. I don't want 30 frames because heart beats very, very fast. It's not like arteries where you can study the flow. So that is why they need high-end systems, and they're exclusively used for cardiac angiograms, cardiac studies. We can't do that, right? But rest of the procedures, any angiogram, you can do that. Conventional ones, right? And contrast, I'll just give you an extra information of what is contrast all about. Whenever you induce a contrast, the first thing is your creatinine will be checked. Your previous history of allergies to anything will also be checked because it can create and cause a reaction called as a mild, intermediate, and severe. Mild reactions, you'll have some bit of scratching, itching, nauseation, a bit of headache. This is a mild system. Intermediate system is called spasms, where you have bronchospasms, laryngospasms. Bronchospasm is your lung. There'll be spasms in your bronchioles. Laryngospasm means your neck, your throat will get into spasm. These are another part of the spasms. Severe spasm is it can cause you heart attack, it can cause you angina, it can cause you convulsion, seizures, strokes, anything can happen to the patient on the table. Even if it is 1 out of 1,000, we never know who's that patient on the table. So it is a very risky. Any procedure has its advantage, pros and cons, and every patient is a very risky patient. It's not like how we do in the lab, just go and click and come. It's not that. The real-time scenario in the field is absolutely different. You need to continuously keep monitoring the patient. You need to have verbal communication with the patient. You have to keep the patient active, communicating. This is what professionalism is all about. Because they're not something like a log where you just sit and you start exposing the blank black and blue. It's not like that. I'm just giving you a little what contrast can really do. Okay, I'll come back to your answer. Where it is used in diagnostic radiology, interventional radiology, it is used in therapeutic radiology, and it is used in image guided therapy. That is in surgeries. When I say diagnostic, is simple procedures. I want to inject at a particular place. So the fluoroscopy guidance will help me to go there and inject. I want to give a spinal anesthesia. I want to remove a spinal fluid. So these are small diagnostic procedures. I'm introducing a tube into the mouth, okay, or I'm putting a drain. I want it to be right at the chest region. So I don't know where it is going from physically from outside. I don't know. So these are the guidelines, the guiding step, which is called as the diagnostic procedure. Interventional procedure is something called as an embolization. Embolization where you seal or stop a blood flow to a particular region. Okay, they're done by injecting some particles into it. Okay, and we have the transcatheteral chemoembolization where a catheter will be put through the catheter. The chemo drugs will be injected so that the blood supply to the tumor will be stopped and the tumor will stop growing. So these are interventional. You're intervening, you're putting a catheter into it and you're going. So this is interventional procedures. Then we also have RF ablation. RF ablation is you use a combination of chemotherapy and radiotherapy. Chemotherapy is a drug, radiotherapy is radiation. Combination, you try to suppress that growth of that lesion. Okay, I'm talking about RF ablation, radio frequency ablations. The other part of this is neuro radiology or endovascular neuroradiology, endovascular surgery. Here it is all about angiograms of the neck and head. And there's something called as a coiling. We have a condition called as an aneurysm. Aneurysm is like a balloon-like structure that will happen in your blood vessel. It can happen anywhere in your body. It will be a bulge like that, and it's very serious because if it opens, then patient might die. And usually it happens if patient have a high BP. There's a lot of pressure on that aneurysm, right? Okay, so they go and try to coil that area. There is a flow diverter which treats this aneurysm. So these are all interventional procedures. Instead of cut opening, they just go into the artery and try to fix this up. Okay, and they are interventional radiologists who do that. Apart from the normal radiologists, these are interventional radiologists. Within the interventional radiologists, we have neurointerventional radiologists who takes up. These are very complicated procedures. Okay, so there again, where you can use your what is that, fluoroscope. Other common uses, as I told you, now this RF ablation, endovascular surgeries, neuroendovascular, interventional radiologies. We have orthopedic surgeries where you do simple fixations. You try to join a broken bone, you put plates into it. So these are simple orthopedic procedures that you can do. You can also do biopsies where you have to take some tissue and send it to find out if it is cancerous, non-cancerous, malignant, non-malignant. That's what I'm trying to say. These are another simple procedures. Spine surgeries where you fuse the entire spine. If you see, sometimes the spine is, we call it as scoliosis or kyphosis, the forward bending and the lateral bending of the spine. So to set that right by doing a fusion. So for all this, you need to use the fluoroscopy will be of a very great use. So to exactly know the surgeon to know that what is he doing? Is he doing it the right way or not? And it shows you in different angles also. As you move the patient, turn the patient, it will show you so that because at one angle you feel that it is right, but at the other angle it might be out. So a radiograph will not show you that, but a fluoroscopy exam will show you that. Okay, just a picture to show you that what is static and what is fluoroscopy. There's a difference about it. Next thing is, somebody can answer me this. I told you about static exposure. Static is nothing but X-ray, radiograph. It is a single shot, a single shot image. So what examples can you give? If I say radiograph, X-ray, what example can you give? Now, what part of body? When I say X-ray, what are the examples? I'm doing an X-ray. What?
Just X-ray
Yeah,
or
simple that. Okay. Just any part of it, just X-ray. What is the purpose of doing it? We try to find out any subtle fractures, any small abnormalities. Okay, whatever we can find, when that's the purpose of doing a static X-ray. Any foreign bodies, something like that. Exposure is just one exposure, just a short burst of X-ray within milliseconds is over. The display will be single image on the monitor. You're not going to have dual image, single image. The timing would be very, very millisecond, just with the blink of an eye or lesser than that, you'll have an image. Motion is you don't get a motion. You cannot see movement, right? You can just see one static image. So that is static image. I just put a question mark just to thought that you can answer. So let's go to the next part of it, the fluoroscopic exposure. Fluoroscopic exposure, as I told you, it's a real-time study. You see, has it happened? And when you say example is, as I told you, different specialties, barium swallow, barium meal, you have your KUV procedures, anything, Ganica HSV procedures, MCU, anything else. Maybe you don't know all that, I'm just trying to tell you. So what is the purpose? You see the real-time motion as it happens. What is happening is what you see. It's a real-time thing. And again, the exposure is continuous. The display is live. There, the display is over, but here the display is live. Timing will be continuous, and here you are able to appreciate the movements inside the body, the motion. So that is kind of a difference between the static image and the fluoroscopy, what you're looking for. I've just summarized this into a table. It's just what I spoke to you about. The image, what it is, and the fluoroscopy, and between the static image and fluoroscopy. Is just that what I told you. And what do we see in a static image? What do we see? We see the anatomy, we see the structures in a single shot. High resolution details will give you. High resolution, as I told you, radiographic images have a higher radiation dose. Higher the power, higher the dose, better the image quality. So it does not mean that every time I go and I give a high dose patient. No, it's not like that. Radiology is all about ALARA principle, as low as reasonably achievable. You do a fluoroscopy, you do a radiographic image, but you do it at the minimal dose to get the maximum benefit or the maximum image quality. This is the principle that everybody in radiology will always follow, called as ALARA principle. Okay. You get very good details, very subtle details, the tabacula of the bone, the structures, any small subtle hairline fracture, which is very hard to detect. And these you are able to appreciate. You can, as I told you, small calcification, that's small nodules, any implants, metal object, foreign objects, you can able to see. But what do we miss there? We miss the motion and function. What is motion and function? The movement, as I give the contrast, as I make the patient swallow the contrast, you miss that movement. And you miss dynamic movements because there's some disease called as a reflux disease, which is very common for everybody now. What happens is when you eat food, you'll feel bloating, your food will come back to you, you feel indigestion. It's just because of that reflux. And how do I study the reflux? I will not be able to see it when I do a static image. As I fluoro and I swallow, I will see that the barium goes, the barium comes out back. So we know where is the reflux happening. So that is a dynamic motion that we're trying to study, which we're able to not achieve in the static. Okay. Real-time guidance is every time you insert a catheter or you insert some wire into it, you're not able to appreciate in a static. So that is what we miss and what we see. It's this other way around for a fluoroscopy system. What we do is we see all the motions are happening. We see the dynamic things are happening. Sometimes we have something called as a hernia. I mean, many people have heard of hernia. That is a small bulge from the body. What happens is that hernia might happen when you're doing a particular function, like moving and sitting and getting up, or when you're breathing. So that you'll be able to appreciate only with the fluoroscopy. As you fluoro, you'll see that dynamic movement of that hernia or the reflux of that barium. So this is how it is used. You can see the contrast flow also. But actually, what we miss in the fluoroscopy, if you're using pulsed fluoroscopy, we will miss in detail. That is, we'll have the resolution of the image will be degraded because you're using a lower pulse range. That is where we compromise. Somewhere we have to compromise. So sometimes what happens is subtle findings, small lesions, calcification can be missed, and it also can be missed because of motion. As you patient moves, even involuntary movements like breathing and all that, what happens is that lesion might move. You'll not be able to appreciate. You will miss it. So these are the little drawbacks what we can really miss on a fluoroscope. Okay. This is just a summary of again what I told you. Then there are different challenges in a fluoroscope. What is the different challenge? Most of the images need to be recorded by the radiologist. So as they keep moving their fingers and hands, they need to record it. There'll be constant movement of the patient, especially when the patient is very sick, when the pediatric patient. And every time adjusting the automatic exposure control. The automatic exposure control is it determines that area where the radiograph or fluoroscope has to be done. It sets the parameters and it produces. If your AAC is not aligned with the X-ray tube, you will have a very bad image quality. So constant movement of the patient, constant breathing of the patient. These all are hindrances and challenges in doing a fluoroscopy where we further need it.
Remember these challenges actually as an analytic, these challenges have to overcome or we have to innovate such a way to your equipment has capable to overcome these challenges.
Okay, that's the reason I put this.
What the end user will expect
to give you.
What about the challenges fluoro proves? That solution, that as a solution. See, for example, your previously when in initial fluoroscopy is coming, we are conventional fluoroscopy is coming, how we are looking? We are looking at a fluorescent image, like a fluorescence image. That's it. See, all these innovations, where we brought it like a real-time image per second has to go 30 frames to 60 frames up to, okay, these all challenges are made by innovation of R&D. Why he showed that, see, fluoroscopy majorly, why we are intending is giving this information to R&D team to bring some innovation in you. Because to tell what is our problems, the end user problems, then you will think based on that, you will bring some innovation. Okay.
The temporal resolution and all that. So these sometimes in the procedure, it is not possible to repeat that instant. Once that instant happens, it's gone. So before it passes, you need to capture it. When I turn this, there is something which is very prominent. So I capture it immediately. Maybe that instant will not come back again. Or the flow of contrast. Once it is flown, if you not capture it, you have to give the contrast back to the patient again. It's your responsibility to see that the patient is at the best comfort. And you finish your procedure quickly, get it first time correct. Okay, and changing the spot image from fluoroscopy to spot image has to be very important. There is again scope for improvement. If it's going to take too long, you're going to miss it again. So changing from a fluoroscopy to a spot image has to be quicker. So few of these challenges that I've just given just for you to just get an idea of it. Okay. And here I talk about the different methods of fluoroscopy. What are the different kind of imaging? So we have a fluoroscopy which has a continuous fluoro or a pulsed fluoro. Then we have a spot image within the fluoroscopy. We have a spot image. Both of them are similar. In fluoroscopy, we call them as spot images, and radiography, we call them as radiography images. The parameters or the apt exposure parameters will always be the same. The dosage will always be the same. But in the spot images, there is an option where you can do multi-frames, up to 8 frames per second. Radiography, it is always single. If I choose 8 frames per second, so one exposure will give me 8 images. 8 images. So that is the little difference between spot and radiography images. Pulsed fluoroscopy, on the other hand, is radiation is generated in pulses. There is a radiation, there is an image, there is a pause or a stop. Again, you have a radiation. Again, there is a pause. Again, you have a radiation. So radiation is not continuous. Radiation is in a pulsed format. But in a continuous, radiation is continuous. Okay. But when you come to image detection, image reading is always in pulsed format. In spite of it being continuous, image readout time will always happen in pulsed, meaning that after an exposure, it's going to take some time for the image to read out. It's going to take some time. Even if the radiation is continuous, the image is not continuous. That is the drawback in fluoroscopy continuous mode. You'll have a lot of noise, you'll have blurry images, which is a real drawback when using a contrast lens.
Yeah, scientist.
Okay.
Thank you for joining.
And I've given you can see that pulse format. What is, I'll talk to you about pulse. Now we have within Philips, we have something called as a GCF system and an ACF system. This is a pulse control system and a grid control system. In the pulse control system, as you see on the second slide, what happens is the system will understand that I need 60 kV or 70 kV for that particular density. But that realization takes place after few pulses, maybe 2 or 3 pulses. So the 3 pulses, can you see here, the ramp up is there. They are radiation, soft radiation, which can impact the image quality and produce unwanted radiation dose to the patient. So before it goes to 70, it takes 40, 50, 60, it goes to 70. Same thing when you off it, what happens is it ramps down. Again, there is a ramp down. So these are soft radiation which can add up to the patient. Okay. But with the GCF technology, we have something called as a grid switch fluoroscopy. Grid switch fluoroscopy is nothing but on or off. Radiation is on, radiation is off. There is no ramp up and down. There is no ramp up and down. So you're removing that soft radiation. You have a lesser radiation dose to the patient. You worked on that. That is a grid switch tube. We also have an impulse technology in the GCF system. GCF impulse technology is automatic adaptation of the parameters according to the different density of the patient. It happens instantaneously. It happens within a single pulse. It takes 2-3 pulses to understand. Here, it immediately understands. If I keep the system on the neck, it understands the neck. I need to give 55 kV. 55 kV is optimized. I move the system down to the chest. It understands the thicker density. It gives you 70, 75 kV. I move it below abdomen. It understands 80 kV. So immediate realization and optimization of the parameters instantaneously. That is why you have considerable radiation dose, lesser radiation dose in impulse technology, okay, which they claim as 68% lesser than other systems, especially very useful for pediatric patients. Okay, so there is a difference between GCF, grid switched, and impulse technology. And within the impulse technology, we also have the IQX, that is a spot image. There also, when I use IQX, it really immediately realizes, hey, this is the abdomen, this is the spine, this is my parameters, and it gives you that. It sends a signal to the generator optimize, set that kV, and send it back to the and exposure. So these are the different methods of fluoroscopy. And why this is important, I'll come to this slide little after this.
We don't need the AC in fluorescence.
See, I'll come to that. I'll come. See, AEC is nothing but automatic exposure control. Either before it was like we had it manually, but now AEC is automatic. So you don't go and play around with the radiation because the system is capable enough to understand what is optimal parameters required. Until and otherwise you want to operate it manually. There is also a lock-in system. I want to tell you the lock-in system is I don't want 70 kV. I don't want the system to optimize my kV. I want to keep it only at 40 because I'm not looking at anything to record it. I just want information. If my catheter is going there, that's all. So what they do within the fluoroscopy, if you press the lock-in button, it will remain 40 throughout your procedure, throughout any part of your body. That's what I told you initially that it depends on the clinical application. These are theoretical, these are by default, but you always have the ability to change it manually and what you are looking for. I'm doing a child. I just want to see a child has swallowed some coin. Where is the coin? I don't want prominent images or good quality. I just want to see. So I'll keep it at 30 kV and just see where it is, whether it is in the throat or is it in the stomach, or it's passed through it. So that's all. So these is a small example I'm trying to give. Okay, you can move man. Online, are you able to hear me? Hello?
Yes.
Yes, well and
I
good.
hope everyone is there.
Yeah. You're audible.
No questions? Okay. Just a picture of the continuous fluoroscopy and the grid controlled fluoroscopy, as I explained how it really works. Okay, this is about the load. Usually, fluoroscopy, people underestimate fluoroscopy dosage. So if you say a 10 seconds fluoroscopy is equivalent to one radiograph with a dosage about 2 to 5 micrograms. Okay, that is the kind of radiation dose you get for 10 seconds with the low dose. Okay, the maximum that you can continue with the fluoroscopy according to regulatory terms. Anyone knows what is the maximum time you can do your fluoroscopy?
In 1.5 minutes.
Okay, I'm talking about continuously. The maximum that you can do is 5 minutes.
10 minutes.
Yeah, right. And you can go up to 10 minutes. Beyond that, it is not ideal for you to continue your procedure because the dose that you're going to give to the patient is going to be considerably very high. And you terminate the procedure, you try to finish it.
Irrespectively, any case, like he explained, there is one procedure. See, for getting a resolution images, once you got a resolution images, you don't require to drive continuously high resolution images entire your procedure. What it's just information is enough. I'm going in a straight way or not. Like when you are inserting a catheter to your body. Okay, while inserting, yes, you require a high resolution image where the incision is correct position. Once it is a correct position, I don't require the high resolution images where I want to use a more dose as you ask, like intensity of a beam. Okay, more X-rays are more intensity beam. Okay, I'm reducing the intensity of beam and going as Alara principle. Okay, with that Alara principle, what I'm doing, I'm achievable with what I want to drive. Okay, that makes complete sense.
This is just an image to show the radiation dose from the table away. Okay, it is nothing but a principle of inverse square law. As the distance increases, the radiation exposure decreases. That is why you have lead barriers, or you can compensate by having 9 inches of wall. Okay, so these are, as you see, the red line, the red, the orange, the yellow. So as you go far, the radiation dose is minimized, lesser. Okay.
Harish, one question.
Yeah.
What is the maximum dose which a person can get in a year? It is 200 millisievert or it's less?
No, it is not 200. It is lesser. They are doses for the radiation worker. They are doses for the general public. I think it is 20 millisievert.
Oh, it's 20
in general. Okay, and
for
this
a
radiation
public
dose can also include all other doses from the atmosphere also.
Radiation.
Okay, cosmic radiation. All
and
the other
therefore,
radiation. So all this accumulate. That's why we give them this dose
TLD
in the image so that they can calculate if they're going for repeated procedures, what is the dose that they have received, and in case the procedure can be done or not.
And this also, I just wanted to bring up this topic because I see a lot of people working on system without TLD batches. So this is very important for everyone to include TLD or have the TLD batch.
We have a session on that also. We have a session on that. Is it Amit?
Yeah, Amit.
Yeah, I have also have a session on that, which will be one of the sessions in this program.
Okay.
So in that we'll have a detail of what is TLD, how it is used, why it should be used, how it is measured, all that.
Why
so
I
for
think
this section,
is important now, which you have already told, right? So we have only certain limit what we should be exposed, even as a worker. So and then you can go in detail later on. That's perfectly all right. Thanks.
Right. Yeah. Welcome. So that's my next slide, and I'm going into it. Yeah.
Like Gary said that the maximum dose, I mean, the maximum 15 minutes that we can any human
5
dressings. So, but 5 minutes not sufficient to do any angiogram.
So you will have a buzzer there which will inform you that you have crossed or reached 5 minutes, and it will also have a buzzer at 10 minutes. Okay, and you also have your radiation dose, your dose area product, your tab will be displayed there. So your physician, the clinician, will be in a position to decide to continue or not. But the regulatory stipulates 5 minutes, 10 minutes, which we have to adhere to. We have to follow.
Because I was part of the, where procedure was going on, I was looking at So it was 1.5 hours continuously. That's it.
Rules are there to break when I go on the wrong side. Okay, it's not that I always go on the right side. So we cannot manipulate. It is our thing according to regulatory. This is what if they're crossing that, we cannot go and question them. That's not our. That is left to their conscience. That is left to what they want to find out. If it's a life-threatening thing, this should not matter. His life is going. I've not put in my stent. I'm going to come out because 10 minutes is not the ideal situation. So let's not debate on that, but that's a different topic altogether. We're talking the set of rules that is being stipulated as a company, and we give it to others.
Just to add, so when we have designed in SIAM in the mobile surgery, so what we did, so at 5 minutes, as you rightly said, there is an alarm, and at 10 minutes there is an alarm plus the X-ray is automatically cut off. So even if the operator is pressing, but it will get reset, so he can again start. Because if the stent is not there, you have to still put the stent. It may take 20 minutes.
His question was, they're doing it for 1.5 hours. Why they're doing it? So
there will be a break. Our system will always stop, and then you can consciously start again. So that's the way we have designed it as per regulatory.
Okay. And just to give you a small example, so I've just given you the radiation dose of 0.015 microgray. This is usually calculated at the last image hold. Okay, and this is for pulse fluoroscopy with a low dose or a pediatric setup. So this is what the dose that you might get per frame. Okay, and when you compare this for an adult, it will be 30 microgray. For pediatric or low pulse, it is 0.015. But if you change the setting to normal or high quality, it will be 30 microgray per frame for an adult. What is the difference? It's like you having a torch into a dark room. Okay, you press the torch, dim torch, you will just see what you want to see. That's all. But when I say 30 microgray, it's like flashing a brighter light into the room. I get better visibility, better detail. That is the difference between 0.015 and 30 microgray. Is what you want to see and how you want to see. Yeah, you see finer, more detail, more visibility. This is nothing but like using a dim light, and that is like a bright light. Spot images, on the other hand, you see it is slightly more 0. So the difference between 0.015 and 30 microgray will be like 2,000 times more in what you're giving microgray that you're going to see if you see the difference. Okay, and the spot images is nothing but like taking a photograph in a dim room without a flashlight. Okay, you just take a picture and you'll see what you want to see. But when I have an adult patient, when I'm going to increase that dose like high quality and normal, this is going to double more. Okay, what I'm going to do is I'm using a professional camera and professional cameras. So it's like taking an ordinary camera with a flash, but using a professional camera with all your features and the lens and all that, you're trying to do capture an image with that kind of a quality. So it all depends on what you want to see. Your feature is there, your specifications are there, how you want to see. But you'll be adding the dose to the patient. Right? And again, dose, when I say, it will depend on the SID, the source to images. It will depend on the patient size. It will depend on what filters that we are using. Okay, so these are where your dose can be calculated. It's not the same dose for everywhere. And as Philips, we give them multiple options, right, from the baby to an extra large to choose according to the patient. And again, the parameters will vary when you choose that.
What is filter and where we are using those filters?
I'm coming to that. I'm covering up all that.
Okay. Even radiography also we have filters.
Okay.
One question, Harish.
Yeah.
So when we are comparing the fluoroscopy with X-ray, static X-ray, X-ray in the sense we're going to take only one single image, right?
Yeah.
Total image of from the phase 2. For example, if you take this as a reference from phase 2 up to the stomach. So in fluoroscopy, will it take the same part of multiple frames?
You will not be able to cover from the face to the stomach at one shot.
Okay.
In an X-ray.
Okay.
It's not possible. But our limit is 43 into 43. That is our detector size.
Okay.
Dynamic, yeah, and whatever we have is sky plate, 14 into 17. So we don't have a detector that can capture right from your head to your abdomen.
Okay, no. I'm saying like there in the static view, we will be having one total view, which make up. For example, I'm saying like if it is a chest means only the chest one static image.
Yeah.
Whereas in fluoroscopy, will it be only the same chest area will be captured multiple times?
No. It is the same image, but you can see it with movement, with motion.
Okay.
What is really happening as you swallow, as you inject?
Okay, got it.
Which you're not able to appreciate in an X-ray or a radiograph or a spot image.
That is correct. Okay.
It's the flow. It's the flow. What you're swallowing, what you find, and when injecting, that's how angiograms are done.
Yes.
As the dye goes into the artery, you're able to see it live, and you're able to appreciate whether you have a thrombus, or you have an occlusion, you have a stenosis, you have a clot. That's how you find out.
So I was thinking like only part by part.
Just give me a moment. If I don't capture it in the fluoroscopy, contrast will flow away. For example, can you see this image here? Can you see any contrast here? There's no contrast. So if you don't capture it in the fluoroscopy, in a radiograph, you only see this. So if you see here, the entire capture is there. You can see the entire contrast, and the entire food pipe, your esophagus is completely seen. If you can see here, somewhere it is narrowing off.
Right. So initially, I was thinking like it will be segment level, like small segments will be captured at multiple frames, and finally it will be attached into a single bigger frame. I was expecting like that.
No. That is also a way called as a conventional angiogram that they do it in the cardiac. They also can do it for the other rest of the body. That is conventional way. When you inject a particular place, you capture the image and keep it. You cannot stitch it later. Right? You can do it individually. That is also possible. But when you do an MR, when you do a CT scan, the entire region of interest can be captured as a single shot.
As a single shot with multiple frames where motions will be captured.
Yes.
Right?
Here, what we need to do is we need to move it part by part, because probably sometimes we are not able to continuously quickly move the system down. Okay. It is for better capture, better visualization and detailed information.
Okay.
Because we are not dealing with CT systems, we are dealing only with radiographic fluoroscopic systems.
Okay.
Is that clear for you?
Okay, it's clear. It's clear. Right.
In a way, clear. So this is about a little bit of a dose. The difference between a pediatric low dose and a high dose for a spot and a stored image. Okay, something to tell you about the spot images. Basically, as I told you already, it is only for documented purposes. You want to store, you want to retrieve the images. And whenever you're doing a fluoroscopy and going into spot images, the switchover time should be faster. Probably if our system has a little bit of a lapse or a lag, we can improve it to see that the switchover time is faster. Then maybe you guys can think about it and work on it. Okay. As I already told you, what captured cost, it gives you 8 frames per second maximum. So one shot you'll have 8 frames per second, and it gives you the real-time images. So this is all about the spot image. IQX also I told you, again it is intelligent X-ray. IQX means intelligent X-ray. Again, it predetermines according to the density, and it gives you that sets the optimal image and gives you that X-ray radiograph for that X-ray. Okay, so that is spot image and IQX. Running out of time. I'll be a little quick. So this is about our proxy system and a combi system. Why we use it is it can be performed for all general radiographic conventional radiographs as well as fluoroscopic procedures. As I told you, for different modalities, you can do it pertaining to your room configuration when you're doing interventional procedures. Okay, so this is a little bit of that. And again, rad images, as I told you, it will be between 2 to 5 microgray per image that we do. The nearby system, we call proxy system as N90 because N means nearby system. So all the procedures have to be done being close to the patient. But with the combi systems, it gives you an option to stand away from the patient, that is stand outside into the console room and perform your procedures. That is why it is called as R90 was remote control. So this is nearby, that is remote control. So proxy, every time you have to be close to the patient and perform your procedures. Okay, and one important difference between a proxy and a combi system is radiation protection, radiation dose that you use. Since the tube is on top, your radiation dose would be slightly more when the tube is bottom. Why? Means you have a direct exposure to the tube when you're standing close to the patient. Of course, you have an apron, but when you do in a proxy system, since the tube is down, we have. If you've not seen it, if you've seen it, fine. You've not seen it, please go to the proxy system and see. We have lead covering, lead lining along the detector. So what happens is the incident rate to the operator is lesser in a proxy system than a combi system. All the combi systems stands apart and has many other features than proxy system. No, I'm talking to people online. They're there. No, so you can see the difference between a proxy system and a combi system. If I'm there, I will show you how it is different, how the radiation dose saving happens between proxy and combi system. But definitely, combi system is far more superior than the proxy system. A little bit of that, and here we have the how it is cost effective is we don't have need additional X-ray tubes and detector to do an X-ray. Within the combi system, you can perform a rad image and a fluoroscopy. So that is why it stays advantageous. It can accommodate bariatric patients, larger patients, because we have a larger table size, about 80 centimeters if I'm right. So that is the kind of and it gives you the best radiation protection. Why? Because you can perform your procedures remotely away from the room. But it is a poor radiation protection if you have to stand closer to the patient. And it's the best in proxy if you're standing close to the patient because of the lead covering, lead lining. So you can see practically in the lab.
Confused with this combi proxy. It means combi combination of radiography and fluoroscopy.
Yes, proxy is only proxy, only fluoroscope. You take another set of X-ray tube and wall stand to do your rad images. Or rad images, I'll explain with the time constraint of time. I will explain to you after this what's it, right? Scalability is they give you a combination to do multiple X-rays, either by using the combination of the tube and the dynamic detector, tube and the sky plate, okay, or you can have the tube and the bucky. There's a many combination of X-rays that can be done with the combi system. If you see here, you can do a fluoroscopy there. You can use the same tube to do. You can use the same tube to do a chest X-ray. You don't have to bring the patient down. The patient can be on the table, tilt the table, position your fluoroscopic tube, which is the first tube, and do your chest X-ray. You can also do cross-table X-rays, where the patient can be on the table, bring the CSM over the table and perform. So these are the different ways that you can use this system in combination to perform almost all type of X-rays. Even if a patient is coming on the trolley, on the wheelchair, you can just take them, keep the sky plate, use a CSM and perform your X-rays. So they're different kind of combinations. So you have a good scalability of how we use the systems. Here I told you about the difference between the proxy system and the combi system, how they help you save dose. If you can see here, you can see the operators here, it is completely covered with lead. The detector is completely covered with lead. Since the radiation would be coming from bottom, it will save you from much radiation along with the apron that you wear. In the proxy system, which is an under table tube. But with the over table tube is directly exposing. There is no cover, no lead cover here, no lead sheets. The operator is directly getting exposed. Here, yeah, he's wearing an apron. He can wear a thyroid shield, goggles, everything, but still is exposed directly. But here, as the beam X-ray penetrates into the table to the patient, whatever scatter radiation, it can save the operator. A little bit of statistical information that I've given of how it helps and saves. Coming to IQX, a little comparison between our competitor Carematic, where when you're switching from fluoroscopy to a spot image, there is a lag of around 2 seconds. It takes 2 seconds for them to do that spot image. That is our competitor. What we offer is there is no lag of time. That realization happens within the pulse and immediately it happens. So we're able to click an spot image immediately from the fluoro to the spot. So this is where we stand out. This is where we have developed and we are there. Okay, there is no need of this adjustment phase where you adjust and go. It is immediately and instantaneously. Another picture will show you, as I explained, impulse technology, immediate realization of the parameters according to the density within a pulse. You don't have to go to the next pulse. Within the pulse, it realizes and gives you that optimal.
Why it's important? You have heard all these things. You showed that various following showed and showed the images of contrast, everything. Why that 2 second lag we want to avoid? Why that is that much important?
That is some exposures. Like 2 seconds is trying to accommodate, so that much exposure will go to the patient, but
not exposure. It is the time of capture.
2 seconds.
So you might miss
whatever.
relevant
You may miss the pathology. For example, likely you are injected a contrast. Okay, you are able to see there is a pathology, and you want to capture that particular movement. And when you switch that capturation, it is lagging 2 seconds, and you are missing that contrast. Actual image you are missing. What you have to do? You have to redo the procedure. Complete contrast you have to redo. See, dose is more. Okay, dose is more to patient. Again, contrast you have to the complete procedure maybe this thing you are missing. See, all this is in a fraction of seconds. Why that much important is because of the 2 second lag also can cause a greater.
We'll finish it fast with time.
Yeah.
As I told, the challenge is in fluoroscopy, so that comes into that. Okay. This dose saving, the optimized IQ, why is it important? Is because you have the right exposure settings. You don't have to go and manipulate them. You have the right exposure, and your exposure happens. Before there's any movement to blur, if the KV has to adjust, it'll adjust within that pulse. So you can overcome that blurring. And with a good temporal resolution, you can overcome that blurring also. And there is, as I told you, automatically it adapts to the anatomy according to the density. It sets its parameters. Okay. And how is it possible? Through a 7-field amplitude chambers, which is the largest in the market. That means you have more combinations to take. As I told you, the part of the anatomy should cover that AAC chamber. If it's not covering, your image quality will be there underexposed or overexposed. Okay, so that is why we have 7-field amplitude chamber where you can use in combination, which another AEC chamber is covering which part of the anatomy, and it is all in default, but you can also change because if the patient is moving too much, then your AC chamber has to be, you have to choose a different AC chamber. Okay, just a little, I'll finish it quickly in view of time. How you reduce radiation? Also, I told you, you use the pulse fluoroscopy, GCF, spot images. Okay, last image hold. So these are the different techniques that you can use to reduce the radiation dose. Clinical user, what he has to follow? As I told you, low frame rates because of LRA principle. Okay, and we have you keep the fluoroscopy every time as short as possible. Okay, and see that all the images, most of the images stored so that you don't have to go back and repeat that fluoroscopy again. Right, and many other dose reduction methodologies or inventions are happening where the dose can be reduced. Just about a curve, I'm not talking about the curve, I'll just talk about spectral filter. In our systems, we have spectral filters, copper and aluminium, 0.1, 0.2 copper and 1 mm aluminium. So you can use that accordingly. What happens when you use it without that particular filter, okay, which is called as a spectral beam, is all the soft radiation reach the patient. And it will give you dose, it will hamper image quality. But with the spectral filters, if you see here, most of the soft radiation is absorbed by the filters. And you get only the primary beam. Primary beam is the beam that we are more focused and which is adequate or which is very important to create an image. It is not the soft radiation, but only the primary beam, the important beam. So that is why we use spectral beam. And here, just difference between using it with the filter and using without the filter. Without the filter is patient dose is 100%, detector dose is 100%. With this filter, 1 mm and 1 mm, 0.1 mm and 1 mm, it is 50% patient dose and 100% of detector dose. That is, the maximum radiation reaches the detector. With 0.2 copper, you can get 70% of patient entrance dose and 100% of detector. Patient entrance dose is the entrance dose that enters the skin of the patient before the radiation. That is, so if 100 microgray is the radiation entering the patient skin, that means patient is getting 100. Inside of the patient's tissue, 100 microgray is going. But the same radiation, when it goes to the detector, it is not. It will be up or somewhere between 10 to 5 micrograms. That's all the radiation, because rest of it goes with scatter, reflection, refraction, attenuation. Okay, that is about radiological physics. I'm just giving you a hint about it. So these filters are very important that we use. So you reduce the radiation dose. Okay, patient entrance dose is the entrance dose to the skin. Detector entrance dose is the entrance dose to the surface of the detector. Okay, and all this again will depend on the SID, the patient size, the filter that we use, what the parameters that you set. And adaptive measuring field. Adaptive measuring field is another technology that we have. That what it happens is, as you collimate, it will measure the area of, which is called FOV, field of interest, or ROV, region of interest, and it will calculate only for that and give you that optimal parameters. It will not take anything beyond that. Before, the technology radiographers have to set that manually, but now we have within that is manual AAC. But in our AAC, we have this adaptive measuring technology where it automatically detects which is the area of collimation and it gives you that optimal image. So this is another feature or another technology that we have. This is our AC chambers, 7 AC chambers. Collimation on last image hold, as I told you last time, it is you have the last image hold. So if you want to collimate, you don't have to expose or fluoro the patient again. You can go to the monitor, you can go to this monitor, and this is the collimation lines. You can collimate to where you want, and then you can perform your procedure, the continuing procedure. Okay, this is the summary of what I told you about continuous pulsed grid control filters, collimation on hold, IQX, and adaptive measuring filters. So this ends my session. If you have any queries, I know I'm sorry for being late and taking it long, but anyway, next time I'm
started little late.
Okay.
So we can compensate with the.
So that's the end of my session. If you have any questions, you can ask me. Others, you can reach out to me. Whatever.